Good morning to all. I'm Deepak George. I'm a DNB trainee in PVS Memorial Hospital. My landmark article today is a surgical technique. It's a upcoming technique, rapid resection and partial liver transplantation with delayed total hepatectomy. In the context of non-resectable colorectal liver metastasis, we have tried a lot of things, starting from two-stage hepatectomy. We tried to embolize the portal vein to increase the liver remnant, and the ALPS procedure, which we have discussed in the past few years, and we ensured into liver transplant. Now, upcoming centers, they have reported very good 5-year survival rates in selected patients with transplant. And the new kid around the block is rapid. It comes from the same center which had a 5-year survival of around 60% in liver transplantation after in patients with colorectal liver metastasis. The same group in Norway, they have come up with this surgical technique, the rapid technique, and they aimed at evaluating a possible strategy to enable liver transplantation in patients with non-resectable bilobar colorectal liver metastasis using small partial grafts, and they planned a two-staged hepatectomy. The problems using a small graft is insufficient metabolic mass, excessive hemodynamic forces on a small vascular bed, and the need for rapid regeneration. Now, they tried to solve these problems by maintaining a temporary native liver for a short period of time. That is, they are not removing the entire liver. They keep a part of the liver and they implant a small liver along with that. The excessive hemodynamic forces, they tried to overcome that by keeping the portal pressure below 20 millimeters of mercury post-transplantation. And they diverted the portal flow from their liver remnant to the graft, just like in the ALPS procedure. They registered in the clinical trials, and primary endpoints were to determine the safety of combined transplantation and hemihepatectomy, followed by a total hepatectomy 4 weeks after the transplant. Inclusion criteria included good performance patients with histologically verified adenocarcinoma of the colon and rectum, non-resectable liver metastasis with no signs of extrahepatic disease according to PET scan, which was taken within 4 weeks of listing the patient. The patients may have 1 to 3 resectable lung lesions smaller than 50 millimeters. And those patients required at least 8 weeks of chemotherapy and satisfactory blood tests at the time of listing the patient for transplant. And at the time of transplant, the liver was completely mobilized from the vena cava, and a partial hepatectomy, 1 to 3 segments of the liver were taken out. And they were carefully avoided cutting through the tumor tissue. They avoided the tumor tissue, and a deceased donor segment 2-3 was implanted orthotopically in that site. And they did the end-to-side the vessel anastomosis and the hepatic genostomy, and the portal pressure were kept below 20 millimeters of mercury, either by doing some procedures like portocaval shunt or splenic artery coiling. But whatever, they tried to keep this was the theory. They actually didn't need in this case, but they will try to modulate the portal pressure below 20 millimeters of mercury. This is the picture. You can see that the vessels are anastomosed. This is the 2-3 graft taken from a donor, and this is anastomosed end to side. The vessels are anastomosed end to side with the main vessel, so that in the delayed total hepatectomy, you won't injure the system. You won't injure this part of the liver which is transplanted. And CT volumetry was done on a weekly basis in the first month, and the patient was on immunosuppression. And once the donor graft, the partial graft which was put inside, which has it's obtained around 0.8% of graft body weight ratio, or 35 to 40% of the standard liver volume, then they would go in again and remove the remnant liver, completion hepatectomy, leaving only the donor segments in place. Immunosuppression using basiliximab, corticosteroids, mycophenolate mofetil, tacrolimus, and after the second stage hepatectomy, the tacrolimus would be replaced by sirolimus. Now, coming into this case, with this theory, they tried to do this case. The case report is about a 50-year-old male with locally advanced rectal cancer with inoperable synchronized liver metastasis. And the patient had 2 small lesions in the right lung. He underwent neoadjuvant chemoradiotherapy and total mesorectal excision and sigmoidostomy. Biopsy came as adenocarcinoma of the rectum, T4N1M1. He was KRAS wild type, so he received cetuximab along with the 5-fluorouracil and irinotecan postoperatively. After the by radiological re-evaluation, he still had non-resectable liver metastasis and no progression of his lung metastasis. So he was included in this rapid study, and PET CT was taken, which showed no other extrahepatic disease other than the already known 2 lung lesions, and he underwent transplant in June 2014. The donor was a segment 2-3 graft from a young cadaver donor. At that time, there were no suitable pediatric recipients available, and the graft body weight ratio was only 0.36. In the recipient, segment 1 to 3 resection was done, and after reimplanting the liver, the portal pressure was measured, which was around 6 millimeters. Now they clamped the right portal vein, which is supplying the original liver, and the portal pressure rose to 14 millimeters of mercury. The target was to keep it below 20, so they did not need any modulations. And they went ahead and fired a vascular stapler without dividing the portal vein. Post-transplant period was largely uneventful. He had ascites, which decreased in the 14 days, and CT was taken on a weekly basis. And by post-operative day 23, an estimated graft volume of 700 ml was achieved, and a second stage hepatectomy was performed. You can see in this picture the initial CT and the POD0 showing the graft and the residual liver. Slowly the graft increases in size, and finally when it reaches this is the place where they took him up for the second stage hepatectomy. Finally, when it has reached 35 to 40% of the standard liver volume, they went in and removed the diseased liver, which had colorectal liver mets. And by 50th post-op day, it had nearly increased to 400% of the original volume. At the second stage surgery, again the portal pressure was measured, and it's only 14 millimeters, and they repeated the measurement 3 times, and finally did the hepatectomy. He had a bit of ascites in the first few days, but it resolved. But again, the ascites reappeared on the POD 50. Now, ultrasound and the CT showed significant hepatic vein stenosis in the graft, and he underwent an endovascular stenting, probably due to the hypertrophy of the graft and kinking of the hepatic vein anastomosis. The ascites production disappeared in 4 days after the stenting, and so the Clavin indograding of the morbidity was 3A due to this endovascular stenting. You can see the laboratory parameters normalizing after the 50th post-op day, and somewhat similar technique was done by Mac et al. There they used a full-size graft of 0.77 graft body weight ratio. They did not measure the pressure. They did a portal vein embolization on the second week. They also had the 2-stage surgeries, but the rapid concept is fundamentally different, and it has more similarity with the ALPS procedure, where you transect the segment 4, segment 2-3 junction, and this inflammatory response to the transection, it was an important signal for the increased expression of regeneration primers in the liver regeneration, interleukin 6 and TNF-alpha. The growth rate was a biphasic pattern. It rapidly increased in the first 14 days after the resection, and then reached a plateau. Finally, when they did the final hepatectomy, the growth rate again increased, and by POD 50, around 400% of initial graft. For concluding, this is only one case. Long-term oncological outcome has not been measured after this immunosuppression and inflammatory reaction. Whether the tumor will reappear or regrow, we are not sure. But liver transplantation has shown to give around 53% 5-year survival in selected patients. And this rapid approach is an alternative strategy to increase the graft availability. So, and the donor morbidity was also less. And the prospect of a living donation, if it comes up in a living donor setup, the prospect of living donation and a decreased donor morbidity is around the corner. So it's a new technique, it's upcoming, we need to evaluate it further. Thank you.